Hello and welcome everybody. Very good evening to this Glaucoma Awareness Month special webinar, which is organized by the Optometry Confederation of India. Glaucoma remains one of the leading causes of irreversible blindness, largely because it progresses silently and is often detected late. For eye care professionals, the ability to interpret perimetry and optical coherence tomography, in short we call it OCT, accurately is critical for every detection, risk stratification, and timely referral or co-management. Today's session, Interpreting Perimetry and OCT in Glaucoma Detection, is designed to strengthen the clinical decision making by bridging test results with real-world practice. Through common pitfalls, empowering optometrists to play a proactive role in glaucoma care and pathways. To give this talk, I would like to welcome Ms. Sangeeta Nagarajan. Sangeeta is a doctoral researcher in vision science, pursuing her PhD through an Indo-Dutch collaboration between the Medical Research Foundation Chennai and Erasmus Medical Center Rotterdam. She has over 6 years of research experience in glaucoma-related vision science with a focus on visual fields, vision-related quality of life, eye movements, and visual perception. Our current work involves eye tracking-based functional vision assessment and analysis of gaze behavior in both healthy individuals and those with glaucoma. She has contributed to the clinical validation of eye movement-based perimetry and actively mentors undergraduate and postgraduate research projects. Her contributions have been recognized through peer-reviewed publications and awards, including the Best Research in Optometry 2022, Excellence in Research Methodology 2022, Judge P.V. Parameshwara Iyer Endowment Award 2023, ESOA Best Research Publication Award 2024, and the Young Investigator Award at IERG 2025. A big round of applause to you, Sangeeta. A lot of work done. And thank you for accepting the invitation. And we really welcome you to the session, and over to you for your expert opinion and discussions. You are on mute.
Yes, because it was being restricted, I was not able to unmute there.
Yeah, okay.
Thank you very much, Paula, for the wonderful introduction. I thank OCI for this wonderful opportunity to take up this session by me. So I will share the screen now. I hope my screen is visible to you all.
Yes, it is visible. Go on.
Okay, then. So good evening, everyone. And for today, I will be talking about how to interpret OCT and visual field reports for the glaucoma detection. So before we get into the main topic, I would like to briefly discuss on how is the retinal nerve fiber layer arranged in a healthy eye. So we know that the retina has 10 layers, but for today's talk, we will be focusing only on the internal 3 layers, which comprises the different parts of the ganglion cell. So if you focus on the inner plexiform layer, it has the dendrites, while the ganglion cell layer is made up of the nucleus of the ganglion cell, while the axons of the ganglion cell forms the nerve fiber layer, which goes and converges in as a optic nerve head. So to summarize, let us take this example. So here I have the posterior segment image of left eye. So we have the macula here, and then we have the optic disc, which is located nasal to the macula. So these 3 layers are found in the macula, but at the optic disc level, we notice only the nerve fiber layer. So let us now see how this nerve fiber layer is arranged in the retina. So from the temporal region, these nerve fiber layers are horizontally arranged and it then crosses over the macula and reaches the temporal part of the optic disc. And superior and inferior arcuate fibers, they then bend around the macula and then they get inserted at the superior and the inferior rim of the optic disc. And then we have these nasal retinal fibers that are entering at the nasal part of the optic disc. So this particular arrangement forms the basis for the universal Isent rule. So what is the Isent rule? So the Isent rule defines that the inferior and the superior neuroretinal rim has a higher retinal nerve fiber layer thickness when compared to the nasal and the temporal part. So any violation to this Isent rule suggests a structural alteration of the optic nerve head. So one such condition is the glaucoma, which is defined as a progressive optic neuropathy, which is characterized by the retinal ganglion cell loss with a corresponding and an irreversible visual field defect. So let us now understand how this glaucoma is formed. So one of the important risk factor for the glaucoma development is the increased intraocular pressure. This goes and attacks the optic nerve head, which causes the loss of the axons as well as the retinal ganglion cell. So due to this reason, here the Isent rule is being violated. So we have battery of clinical tests that are available for diagnosing glaucoma. So among these, the optical coherence tomography is used for the structural assessment, while we have the perimetry, which are nothing but the visual field evaluation for commenting about the functional status of the individuals with glaucoma. But it is very important to remember that none of these test reports can be interpreted independently. They must always be correlated with each other whenever we are going to, before we arrive at the diagnosis. So it's a question time now. I think Sakina will initiate the poll. So can the participants respond in glaucoma? So which is detected first? We have structural loss, we have functional loss. So could you all answer the poll? So Sakina, has everyone answered the poll? Because I'm not able to see the responses here.
Yeah, 66 out of 93, they're still responding. So I think we can give them 10 more seconds.
Okay,
and
yeah,
we'll
sure.
end.
Yes, yeah. Okay, so now I see the result. 49% responded structural loss and 51% responded functional loss. Okay, let's now see what's the right answer. The right answer is the structural loss. Let me explain why. So in glaucoma, usually the structural loss often precedes the functional loss. So first, let us see how to measure the structural loss through the OCT. So this is a non-invasive technique, which uses the principle of low coherence interferometry. So we have 3 scans that are taken during the OCT measurement. So the first scan is taken at the level of macula. So here in the macula, we have the ganglion cell layer and then the inner plexiform layer. So here, this OCT gives us the combination of ganglion cell plus inner plexiform layer thickness. And the second scan is taken at the level of optic nerve head, so which provides us the details about how is the rim area and then how is the cup to disc ratio changing, and then about the cup volume and then the disc area. All these values that are related to the optic nerve head will be provided through this scan. And then we have a third scan, which is taken around the optic nerve head, which is at the peripapillary, which measures the peripapillary RNFL thickness. So here we get average RNFL thickness and also quadrant-wise how the thickness is changing. So we will see all these in detail when we look at the interpretation in depth. So, but before getting into the interpretation, it is very important to understand whether the report is reliable or not. So the first thing is to decide on the scan quality, which is decided based on the signal strength. So here I will be discussing about the OCT reports from the cirrus. So hence for cirrus OCT, we rely on the signal strength of greater than 6 on, which is out of 10. And then there should be correct documentation of refractive error, because for example, in high myopia cases, there can be physiological thinning that can be already evident in those individuals. So it is important for us to document the refractive error. And then we have to ensure that the region of measurement is properly placed, which will again ensure the proper segmentation of the sectors. So while we take a scan, the region where we measure will be marked through a smooth line. So that line needs to be remaining smooth, and it should not have any interruptions. If there is a break or interruptions in those lines, then that will affect the segmentation of the sectors. So, and then we should also rule out the criteria, rule out the factors which can cause false thinning. So these are the few factors which can induce the false thinning. So now we have taken 3 OCT scan reports, but the OCT mission gives these scan report as 2 consolidated reports. The first one is about the ganglion cell analysis. So here, first report, when you see here at the topmost part, we see the thickness map. This is nothing but a heat map. In this heat map, the warm colors indicate that it is having a normal ganglion cell and inner plexiform layer thickness. So, and then we have the deviation map, which is generated by comparing with the normative database. So here, this thickness map and the deviation map are color coded oppositely. So if you see red color in the thickness map, it is good. While if you see red color in the deviation map, it indicates thinning of the ganglion cell and inner plexiform layer. And then based on this deviation map, the sector-based thickness are provided by the OCT mission. So here again, the green shows that it is showing normal thickness, while the yellow indicates borderline thinning with red indicating definite thinning. Okay, so based on this particular report for both right and the left eye, we see we don't see much of red regions here in the deviation map, and then the sectors are also showing a green color. So this represents a normal ganglion cell and inner plexiform layer thickness. On the other hand, if we see this report that is on the right side of the slide, so we notice that the deviation map is showing global red color. So most of the regions are colored in red, showing that there is a global reduction in the thickness of the ganglion cell and the inner plexiform layer. Well, when we look at the left eye's report, it is showing a focal thinning, which is restricted to the inferior region, as you could see here. And this can also be correlated with the sectoral map here. So this sort of thinning is suggestive of glaucomatous changes. So the next report that the OCT mission provides us is the ONH and RNFL analysis map. So here again, we have the thickness map. So here again, the red color or the warm colors correspond to normal thickness. So here the normal RNFL has a typical pattern. So it is it will either look like a hourglass shaped or an inverted butterfly shape, as you could see here, because as it is following the isyntrol, because the inferior and the superior RNFL has the greater thickness when compared to the nasal and the temporal. Similar to the ganglion cell, here again the deviation map is color coded in an opposite way to that of the thickness. So if you see red color in the deviation map, then that indicates thinning. But here we don't see any red marks. So here the thinning has not started to occur. And the third parameter, what you have to focus on here is the Tisnett graph. So what is this Tisnett graph is, so the RNFL layer thickness is measured by starting from the temporal region, and then it goes to the superior, and then the nasal, followed by the inferior, and then it again ends at the temporal region. So in the x-axis, we have the quadrant at which the thickness is being measured. So this is usually said to have a double hump pattern, because again, to align with the Tisnett rule, that is the ISNT. So the superior and the inferior region should have the greater thickness when compared to the nasal and temporal. So when you see this classic double hump pattern, then we can say that the RNFL thickness for that patient is within the normal limits. So in addition to this, we also have a quadrant and clock heart thickness, similar to what we saw in the ganglion cell analysis. The same color code applies here also. Green represents normal, while the red will indicate a definite thinning. So apart from that, we also have a summary table, which is derived out of the optic nerve head scan. So here we see average RNFL thickness and also retinal nerve fiber layer symmetry. So this is the proportion of symmetry between the right and left eye of that particular individual. And then we also have other factors like the cup volume and disc area are also given here. So on the other hand, if you see this particular report, here the deviation map shows red regions, indicating that there is thinning happening in the superior and the inferior region. And similarly, we also see more red region in the inferior when compared to the superior one for the left eye. When we look at the Tisnett graph, it is not showing a double hump pattern because the lines are becoming more flat and it is entering the red zone here. So you can visually compare between the normal one and the abnormal one. So again, the sectoral map is showing both inferior and superior thinning for the right eye and an inferior thinning for the left eye. So this sort of thinning is usually observed in a glaucomatous eye. But again, because we get two reports from the OCT, so it is usually both the things need to be correlated before we arrive at a diagnosis. So if you see here, both the GCC and then the RNFL analysis, both the maps are seeming to be within the normal limits. But again, even though we are measuring the structural loss with the OCT, we will also have other disc images and also the 90D that has been done by the practitioners usually. So this report again needs to be correlated with those clinical findings. So here again, I have another example. If you see here, the right eye shows borderline thinning of ganglion cell layer. But when we look at the RNFL, we again see an inferior definite thinning that is noted in the right eye. But the left eye shows in an advanced thinning of the ganglion cell layer with overall depression that is noted here for the RNFL2. So here both the reports seem to be correlated. So both the reports here, when we analyze it together, it is suggesting that there is some glaucomatous changes that have been noticed. So here I have a scenario. So if you see this particular OCT report, we don't see any colors. It is appearing fully in white. So these sort of reports usually occur for two scenarios. Whenever you see a white color report like this, it usually is noted when the RNFL thickness is increased. When you see an increased RNFL thickness, it is coded in white. So when we don't have a normative data for that particular age group, because for lesser than 18 years, we don't have the normative data. So for those population, due to the non-availability of the normative data, the whole report is coded in white. A similar kind of thing can also be observed in adults, where the thicker RNFL can be visualized in the optic neuritis or optic disc edema cases. So now that we have understood about the OCT interpretation, which is a structural measure, let us now move on to the functional vision assessment, which is the visual fields. So here, before we go into the visual field interpretation, I just want to give a brief introduction about what is a visual field and its relation to the neural structures. So a visual field is defined as the extent of peripheral vision when you fixate centrally. So these visual fields are processed by the contralateral retinal and the brain structures. So let me try to explain this through an illustration. So here, although here you see a binocular visual field representation, but for simplified explanation, let us just consider the visual field of the left eye for now. So here we see a house with a roof. So in this visual field, the roof of this house is falling on the superior visual field of the left eye. So when the light rays enter the eye, it passes through the convex lens. Due to its optical properties, it forms a vertically inverted and also a horizontally flipped image on the retina. So if you see here, the roof which is available, which is visualized on the superior visual field, goes and falls on the inferior part of the retina. So these inverted image is then processed and through the optic chiasm, and then it reaches the visual cortex for the further visual perception process. So due to this optical phenomenon, visual fields are processed by the contralateral retinal and the brain structures. So to put it in simple terms, in glaucoma, if you have an inferior structural loss, it is evident as a superior visual field defect in the visual field report. I hope this thing is clear. So now let us see how to measure the visual field. So perimetry is a clinical test that measures both the visual field extent and also the sensitivity at each test location. So here we have the monocular visual field extent. It is usually greater at the temporal side and it is a bit restricted on the nasal, superior and the inferior due to the presence of nose, eyebrows and the cheekbones. And then below I have the monocular and binocular visual field extent. So binocularly, if you extend the field of vision is extended up to like nearly 190 degrees. But at center, if you see, the binocular overlap is visualized for nearly 120 degrees. So here this image represents the functional representation of the visual field. So here we have the fovea, which shows a higher retinal sensitivity at the foveal region. So when we go from fovea to the periphery, so the retinal sensitivity keeps dropping. And at a particular point, which is exactly 15 degrees from the fovea, we see a very deep drop in the visual, in the retinal sensitivity, which is called as the blind spot. So the blind spot is nothing but it is corresponding to that of the optic disc that is seen within the retina. So we have different methods for measuring the visual field, but the gold standard is the standard automated perimetry, which is widely used in the clinics. So one such standard automated perimetry is the Humphrey visual field analyzer. So it is called as a white on white perimetry. Why? Because it has a light gray background on top of which we will be projecting different intensity white light with a Goldman size 3 as its size. So then we measure the retinal sensitivity. It is defined as the ability of an individual to detect the dimmest stimuli. So based on that, the retinal sensitivity is measured in decibels and the values can range from 0 to 50 decibels. 0 indicates a very poor retinal sensitivity, while 50 decibel corresponds to a very good retinal sensitivity. So these retinal sensitivities can be measured by using different test strategies. We have full threshold, CITA standard, fast, and then the faster. So these based on the test strategy that is being selected, the test duration of the visual field testing would vary. So this slide shows the different test programs that are available in the Humphrey Visual Field Analyzer. So each dot on the grid represents a test point which corresponds to a particular retinal location. So by testing these points, we will be able to map how is the retinal sensitivity decreasing across the visual field. So in case of glaucoma, we use mostly 24-2 or 10-2. Why 24-2? Because it tests 30 degrees nasally and 24 degrees temporally. Because here we wanted to know more of nasal visual field, how the nasal visual fields are appearing, because one of the most sensitive region in the optic disc is the temporal thing, because it has the temporal fibers that are entering through that space. Hence, we are testing more points in the nasal region. And then we have 10-2, which tests the central 10 degrees of the visual field. So whenever we see a paracentral defect, which involves the central points, then this particular test grid is being used. And then we also have a recent development in the visual field testing, which uses 24-2C. So this particular paradigm combines both 24-2 and 10-2. If you could see here, it has few additional test points in the central 10 degrees. So now let's get into the HVF report interpretation. So we have 8 zones in total. So let us take a deep look at each one. So the zone 1 covers the general information. So the first thing is age, because the retinal sensitivity which are being measured in HVF, that will be compared with a normative database. So hence we have to document the age correctly. And then the strategy which is used needs to be also checked, because if you want to compare different visits visual field report, then that needs to be constantly maintained at the same strategy. And then the refractive error needs to be documented, because that decides how much correction lens needs to be put before the eyes while we test. And then the visual acuity needs to be noted down, because this particular visual acuity should be correlated with the foveal threshold that we will be measuring. And the pupil size matters a lot here, because miotic pupils can cause diffraction and can lead to unreliable test results. So the second zone is about the reliability indices, where the first one is a fixation loss. It is usually measured through a particular method, which is called as Hagel-Krauge method. So here the stimuli is presented at the blind spot region of the individual. So if the patient is responding while the light is shown on the blind spot, then that is considered as a fixation loss. But for the false positive, these are the responses when the patient responds when there is no stimulus is actually shown there. So when the patient keeps on pressing the button, then that is called as the false positive error. And then we have the false negatives, which indicate the tendency of a patient to miss a stimulus where they should have actually seen that particular stimuli. And then we have the foveal threshold, which again needs to be correlated with the central vision. So when the patient has a very good central vision, the foveal threshold should also be showing a better decibels here. And then we have the gaze tracking to monitor the fixation. So here, any deflections that are noted, upward deflection represent that there is a fixation loss. Any downward deflection corresponds to a blink. So here I have few unreliable visual field reports. So this is a classic clover leaf pattern that is noted when there is a high false negative responses. These patterns are usually seen in patients who experience more fatigue or they are not paying attention to the test. Then in those scenarios, these sort of defect can be seen. And then we have white scotoma. So if you see here, most of the we don't see any gray points here. It is totally white. So which is usually seen in case of higher false positives. And then if you see here, we notice a constant blacked out region in the edges alone. So these are usually caused when due to the rim artifact. So when the lens is not placed correctly, due to those things, this sort of rim artifact can happen. Then we have zone 3, which is the numeric plot. This has the raw threshold values from the measurement. And based on these numeric plot, this grayscale is developed. But usually grayscale is not used for interpreting the visual field defect because this can over or underestimate the defects. But rather, this grayscale is used for counseling the patients about their visual field extent. So with this grayscale, we will also be able to detect which eyes visual field report are we seeing. So usually, if you see here, we see a darker region here, which corresponds to the blind spot. So if the blind spot is on the left side, then that is a left eye visual field report. We have the zone 5, which is the total deviation plot. So here the raw thresholds are being compared with the normative database, and the difference or the deviation is plotted here. Similarly, the probability plot shows the deviations that are less significantly observed in the normal individuals. From the total deviation plot, we derive the pattern deviation plot by adjusting to the internal noises or the other factors such as the media opacity. So this produces whether there is a true scotoma or depressions. So usually the pattern deviation plot is mainly used for detecting the visual field defect pattern. So whenever you see a cluster of a significant defect that are usually noted in the non-edge points, that is by leaving the outer region of the visual field test points, if you notice any cluster of defect points in the non-edge regions, then those indicate a significant scotoma. Next is the glaucoma hemifield test. So here the visual field is horizontally split into superior and inferior hemifield. And within the hemifield, it is again being split into different zones. And each zone on the superior and the inferior hemifield is then compared for the retinal sensitivities. So based on those difference and its statistical significance, it is being flagged as whether it is within normal limits, borderline, or outside normal limits. The zone 8 is the global indices, which provides a summary of the visual field sensitivity. So here we have the mean deviation, which is derived from the total deviation plot. So a normal MD should be less than -2 decibels. And then we have the pattern standard deviation, which is derived from the pattern deviation plot. So here, any higher positive values indicate that the patient is having a more focal defect, that is at a particular region when compared to a global defect. And then we have visual field index, which represent or gives us it represents how intact is the visual field in the percentage, which ranges between 0 to 100%. So here 100% means the visual field is perfectly intact. We have a special criteria for detecting whether the visual field defect is caused due to glaucoma or not, which is known as the Anderson's criteria. So it has 3 points inside it. If any 2 criteria are satisfied among these 3, then that particular individual is said to have a glaucomatous visual field defect. So the first thing is the pattern deviation plot should show a definite depression. The second thing is GST flagged as outside normal limits, and the pattern standard deviation showing a p-value that is less than 5%. So now we again have a question time. So can we have the question on the poll? So can you respond like which feature best describes the glaucomatous visual field defects? So are we getting responses, Sakina?
Yes, we're getting responses. We will end the poll in
Okay,
5.
no problem. Yeah, sure.
In another 5, 4, 3, 2, 1. I'm ending it.
Okay.
Yeah.
Okay, it is nice to see the results here. So 86% of them have responded that the defects would definitely follow RNFL arrangement. Yes, of course, that's the right answer. So here now I have some of the common visual field defect patterns that are seen in glaucoma. So unlike neurological visual field defects, as you all mentioned, the glaucomatous defects usually do not have a sharp or well-defined borders. Rather, they follow a characteristic pattern of the anatomical arrangement of the retinal nerve fiber layer arrangement, which we saw in the first. Say, for example, let us assume that the inferior arcuate fibers in the retina are affected. So that you see a superior arcuate defect as you see in this example. Say if the temporal part of the disc is affected, then you see a nasal step or the nasal defect. So this is how you have to interpret the visual field defect pattern. So here I have a sample visual field defect report. So the major thing that needs to be focused when you are interpreting a visual field report is first you see which report are you interpreting, and then look at the reliability indices, and then directly go into the pattern deviation plot, because this will tell us whether there is a true depression noted or not. So here we see that there is a cluster of more than 3 points at the non-edge level. So, and if you look at the pattern, it is following arcuate shape here, because it is exceeding the vertical meridian and it is going like this. It is also having a curvy shape, which is at the inferior region. And then when we look at the GHT, it is flagged as outside normal limits. And when we look at the pattern standard deviation, it again shows a P that is less than 5%. So now it is following the Anderson's criteria. So we name this defect as early inferior arcuate defect. So similarly, when we look at this particular report, it is again reliable. But in very advanced cases, the whole field gets depressed. So in pattern deviation plot, we get only the focal defects. So when the whole field is depressed, the pattern deviation plot won't be projected. We have to rely on the total deviation plot, which shows depressed points all over the field. And this indicates advanced field loss. Here I just have another example. It is again a reliable report. And when we look at the pattern standard deviation, this is a right eye's report, and this region is the nasal part of the visual field. So where we see many depressed points, but the GST shows borderline, but the PSD is showing the P that is less than 5%. Hence, this again satisfies the Anderson criteria, which is a nasal defect. But again, these visual field reports, these cannot be interpreted independently. That needs to be correlated with the structural laws that are noted either in the OCT or noted in the examination of the optic nerve head. So here I have an example. So if you look at the right eye, this is the RNFL report. So the right eye shows inferior and superior thinning for this patient. But when we look at the visual field report, it has not shown an evident visual field defect. So which means that this aligns with the statement that functional vision precedes the structural loss precedes the functional vision loss, because here first we see the structural loss, but we don't see an evident functional vision defect that is noted here. So this indicates that in right eye the patient has a pre-perimetric glaucoma, while if we look at the left eye's report, you see there is a thinning at 3 quadrants. And then the visual field report also shows an advanced visual field loss, which indicates that the left eye is having a very advanced stage of glaucoma. So now we have seen how to interpret OCT and visual field report. Now let us see how these two can be used as a tool for monitoring the disease. So, which is nothing but the progression analysis. So I would like to explain the progression analysis by splitting them into small questions. So first thing is, why do we need this? Because we need to understand whether the glaucomatous changes are being stable or worsening, because this enables us to decide on the treatment, whether to continue the same treatment or to change the treatment modality. And when to use OCT progression and when to use a HPF progression. So usually the structural things are structural progression is mainly relied in early or pre-perimetric glaucoma cases. Why? Because in case of advanced stage of the disease, due to very poor thinning of the GCC and then the RNFL layer, the OCT machine will not be able to detect further thinning, so hitting the floor, which is called as the floor effect. So thus in the advanced stages of glaucoma, we don't rely on the structural progression, rather we focus on the visual field progression for the moderate or the advanced glaucoma stages. And then for both OCT as well as the HPF progression, we would require 2 baseline reports and at least 3 follow-up reports to say whether the progression is occurring or not. So this is done using 2 types of analysis. The first one is the event analysis and the second one is the trend analysis. The event analysis will tell us which location is showing progression consistently, while the trend analysis will tell us how fast the progression is happening. So let us first take a look at how the progression is happening structurally. So this is the RNFL progression analysis. So for this patient, we have around 7 visits, where the first 2 visits are taken as the baseline. So at the 7th visit, the event analysis flags this particular region. So whenever you see a red region, so it shows consistent thinning across the visit. So we can see that both the superior and inferior regions are showing consistent thinning, that is the repeated thinning across the visit when compared to the baseline. And then we have the trend analysis. Usually these trend analysis are nothing but regression analysis that are done for this particular thickness against the age, and then a line is being fitted. So the slope of the line tells us the rate of progression. So if you see here, the average, the superior and the inferior RNFL is showing progression based on the rate of change. So this particular RNFL progression analysis is showing consistent thinning with progression that is being noted. So again, we have the similar report for the GCC complex. So if you see here, again for the last visit, the patient is showing consistent thinning, which is evident in the event analysis. When we look at the trend of the line, it is also showing a bit steeper line, if you could see here. So which is suggestive of that the progression in the superior and the inferior ganglion cell layer is happening. So here I have an example to highlight the need for selecting appropriate baseline reports. So this patient has 8 visits. So as usual, by convention, the first 2 visits report were considered as the baseline. So when they looked at the progression, it was showing evident thinning in both event as well as the trend analysis. But the one thing what we have to notice here is the patient was surgically intervened after the 4th visit. So whenever the patient is going to be intervened either surgically or medically, then we have to change the baseline report. So for the same patient, on considering the visits just prior and after the intervention, which is kept as the baseline now. So we now notice a drastic change in the event as well as the trend analysis. Because here, if you see, we don't see much of consistent thinning or no progression is being noted, which tells us that that particular surgical intervention has helped this patient to have a stable structural function. And then we have the HVF progression analysis. So here the event analysis shows which test locations are showing consistent progression. So whenever there is a consistent progression when compared to the baseline, it will be flagged with a fully filled triangle. So the main criteria is if the report shows 3 or more such filled triangle points, then that particular patient is said to have progression in the Visual field defect. Similarly, we have the trend analysis where the visual field index is plotted against the age, and then the slope of the line will give us the rate of progression. So if you see here we have a cutoff. If the progression or the rate of progression is going to cross 1%, then it is said to have a rapid progression. If you look at this values, it is showing minus 4.5, which is suggestive of this particular patient is showing a rapid progression. And then we have an example of a stable visual field defect report. If you look at the trend analysis, it has not shown much progression, and even the event analysis has not flagged any points with the fully filled triangle. So this is suggestive of a stable visual field report. And then we have a visual field progression analysis, which indicates a very slow progression. So when we look at the rate of progression, it is showing -2, so which is greater than the 1% change. And then the event analysis flags more than 3 points as a fully filled triangle. So for this particular patient, we see that there is a slow progression of the visual field defect. So with this, I would like to summarize today's talk. So we know that the structural loss precedes functional loss in glaucoma. So usually the OCT is preferred for the early detection, while the visual field can be used for managing the disease at the later stage. And then we have to always correlate the structure and the functional loss that is being noted in glaucoma. And then for OCT, we have to have a very good signal strength, and then we have to ensure that there is correct segmentation. Both GCIPL and RNFL factor needs to be taken into account. And for HPF interpretation, check for the reliability of the visual field report, and then use Anderson's criteria for the visual field defect pattern identification. And then going on to the progression analysis, we have 2 things. Both the things needs to be considered, the event as well as the trend analysis. And then while we do a progression analysis, be it OCT or visual field, whenever there is going to be a change in the treatment, based on that, the appropriate baseline report needs to be selected. So with this, I end the talk, and I thank OCI for this wonderful opportunity again, and I'm open to questions.
Thank you, Sangeeta. Yes, so I'm opening the house for questions. We have some questions in the chat. I'll just check. Okay, Mohammed Qasim Khan initially asked, what is peripapillary atrophy? If you can.
Peripapillary atrophy, it is around surrounding the optic disc area that is called as the peripapillary region. So due to the aging or other clinical conditions, there can be cell death that could have happened, and due to that thing, usually in OCT there will be a false thinning that will be shown. So that is called as the peripapillary atrophy.
Okay. Then there was one more question. The blood aqueous barrier is formed by? I think it's a question. I mean, the blood aqueous barrier is formed by what? I mean, Kasim had only asked. Kasim, maybe you can unmute yourself and you can ask the question yourself. This is like an incomplete question. Sakina, can you help him unmute, please? Okay. Meanwhile, Dr. Meena is asking, with family history of glaucoma, should we do OCT regularly?
I would not suggest to do OCT regularly, but it would be nice to have a regular comprehensive evaluation, because we will be able to see whether there is some structural changes at the level of the anterior segment, how are the angles, and then the intraocular pressure, and then even the optic disc can be evaluated using a 90D in the routine OPD. So first thing would be comprehensive evaluation. So if they notice any alterations in those clinical tests, then I think the OCT would sound better.
Okay. When to perform 24C program?
So yes, 24-2C program can be performed in patients. If you see, a few patients will start to have the defect from the paracentral region. So in those patients, rather than doing a separate 24-2 and then 10-2, we can directly go in for a 24-2C program, and we can also save time in that.
Okay. How to correlate optic disc findings in regards to HVF and OCT findings?
Okay, so usually the optic disc findings would directly correlate with the OCT finding, because both the things are measuring the structures. So the optic disc, we will be qualitatively assessing it, but OCT will give us the quantitative measurement. So when we notice the changes in the OCT, then again, the opposite. So, for example, if the superior region of the structure in the OCT is affected, then evidently the inferior visual field should have been affected. Yes. So, in that way, we can correlate.
Okay. Is there any particular research paper you have referred to say that structural defect comes first? What if they are happening at the same time?
Okay, so we have many research papers to support this particular statement, because in some patients, maybe if the patient is diagnosed at the later stage of the disease, maybe both the structure and the functional thing can be happening in parallel. But usually in glaucoma, the structural loss precedes the functional vision loss, because we have many things that are many new tests and new protocols that are developed, both from the OCT and also from the visual field end, for the earlier detection.
Okay, great. So in the interest of time, I think we have to wrap, because we are already time. But from my end, I just wanted to ask one question, Sangeeta, is See, when we talk about optometry practice, we are looking at private practitioners who are having their own clinics, and then OCT is something which is like an institutional based, because everybody will not be able to afford an OCT machine or do that in their private clinic. So, according to your experience, what should a private practitioner do, to basically diagnose and then refer, and how can this, the discussion which we had today, the insightful discussion which we had, how can they make use in their practice? What will be your advice? Yeah.
Okay. I think so the OCT is the only golden standard that is available for measuring the thickness. Maybe in case of individual practitioners, I would ask them to have a tie-up with some tertiary eye care clinics, because they will have access to the OCT instruments there, where the patients can go get tested and then they can come with a report to the practitioners. So in that way, the management can be maintained.
Okay. So yeah, I guess private practitioners should have this kind of a relationship with the nearby institutions that will make their practice more. I would say it will be easier for them to practice these specialities. Yes. So thank you so much, Sangeeta, and for giving your time. It's almost been 1 hour. We have been listening, and then we are not getting bored. So this we can go on and on. But yeah, so I think
Thank you very much.
yeah, today's discussion, it has really reinforced the critical role of optometry, playing what we do as in case of early detection, appropriate referral, and then ongoing monitoring of glaucoma, especially for a condition that is so often silently is silent and yet irreversible. So we also really thank all the participation. It's a huge, success, because we have so many participants today spending their time coming in the afternoon. I'm sure a lot of you are working, and it's a weekday. But really, thank you for sparing time and
Thank you
coming
very
to the
much for the
session.
opportunity. Yes.
Yeah.
Yeah. It was
So
great
now,
and it was a nice experience. Yes. Thank you very
yeah.
much.
So now, for all the participants, just a few information from OCI. As a professional organization, we kind of try and develop ideas which can help you create awareness among your patients in easier languages. So that is why we kind of come up with IEC thematics every month. So according to the eye health calendar, January was supposed to be glaucoma awareness month. So Sakina, if you can just put the IEC material, we have already launched it, but because we are ending this month with this great talk, I would try to reiterate that you can use these available resources for yourself. These are made for you. You can use them to talk to your patients, start conversations, put it in your clinic with your logos. If you want your practice logo to be put in the IEC, you can write to us at info@ocindia.org, and we will be really glad to put your logo and give that back to you. Please make use of these IEC materials, because they are very easy in language, very easy to understand for the common people. It will help you start conversations with your patients, because many a times there is the barrier that why should I even talk about this condition. So just keeping that brochure or that IEC material will start that conversation. So this is the one. You can write to us, and we will be happy to share it with you with your logos, or in anyways we can do that for you. The other thing is, we February is supposed to be the low vision awareness month. So we are launching the second phase of the educational series on 8th of February to honor the Low Vision Awareness Month. It will be a 6-session series, and the lectures will be on every Sunday morning. OCI, in association with Omtau Scientific Apparatus, we will be providing low vision startup kits on subsidized rates, because a lot of private practices, we do comprehensive eye examination, but I don't know if you are stuck somewhere that you really do not have access to these kits. You don't know where to order. So we have brought this beautiful kit. It's a basic kit with a logma chart, with a telescope, with a handle magnifier, Amsler grid, which will at least help you start your low vision practice. And along with that, you will learn with the series basically. So you can register, and the first lecture starts on 8th of February and it will go on till 14th of March, every Sunday, 1 hour of lecture. There will be also a panel discussion, and then if you are really interested to book the kits, you can let us know. The registration link is in the chat box for you. And yes, so these are the small initiatives OCI has been doing long for optometrists and for the fraternity. And for those who have not been able to join today, it will be available. The lecture will be available as an e-resource in the OCI website. You can always log in and attend the lecture. Yeah, so thank you, Sakina. Well, we have overshot by 4 minutes, I think, but Sangeeta, really, appreciate heartfelt gratitude that you spent your time. Thank you so much.
Yeah, thank you so much.
Yeah.
Yeah.
Bye.